Turpening from Wake Forest University School of Medicine in Winston-Salem, North Carolina, the United States. And I am one of the Academic Radiology Education Program or AREP team members. We are a small group of radiologists from Southeast Asia, Nepal, Bhutan, Iraq, and the United States. We broadcast radiology webinar on the first and the third Sunday of the month. Before we start, I would like to make a few announcements. The first announcement, at the end of the webinar, we will have a survey to improve our program. Please help us by completing the survey. For registered members who join the webinar by Zoom links in your email will get a certification of attendance. And we will have a quiz question at the end of the webinar. Dr. Panatapura, my colleague, will present you with the quiz. Please have your phone ready to scan the QR code to answer the question. We will have a polling time today for 3 minutes. A lucky person who get to right answer this month will get a gift. Since we have approximately 20 to 30 people gets right answer, we need to randomly select a lucky person. I guarantee there's no bias in that. And about the third announcement is AREP mentoring is for radiology residents is coming up next Sunday at the same time. It is challenging cases in body imaging. I will send out the flyer and the link to your email address. So keep an eye on your email. And this one is the new program that we just launched, the Radiology Roundtable with medical students. For our folk who are interested in having your medical students to at your institute, wherever you are, to join this roundtable with medical student program with us, please contact me. Group of people who led this program is senior radiology resident at Wake Forest. So they are pretty good about that. Now it is time. Today it is a great pleasure to have Dr. Omar from IBN Sinai Hospital from Sudan as our moderator. And Dr. Omar's expertise is hepatobiliary imaging. And I would like to pass this task on to Dr. Omar. Dr. Omar, please.
Oh, thank you, Nat. Thank you, Nat, for having us here with you in this platform. And thank you for organizing such a good platform and for having me as a panelist in your session. I am Dr. Mahal Omar, hepatobiliary pancreatic and GI imaging radiologist, head of the radiology department at Ibn Sina Specialized Hospital in Khartoum, Sudan. I am honored and more than privileged to present Dr. Marta Terrazas with an impressive CV. Dr. Terrazas is subspecialized in MRI, MSK, and body imaging. Currently, she is a staff at the Department of Regional Radiology, Cleveland Clinic Imaging Institute until 2022, and for 4 years, Dr. Terrazas was an assistant professor of abdominal imaging at University of New Mexico Hospital. Dr. Terrazas has many researches, including recently accepted abstracts in RSNA 2021. The most interesting among others is ensuring your LIRADS reporting is in mint condition. Dr. Terrazas is a lady of many awards and honors. She was awarded the best teacher in abdominal radiology for 2 years in a row in 2019 and 2020. Lastly, Dr. Terrazas is an active radiologist. She is a member of 4 radiology societies and having a total of 6 publications. Today, Dr. Terrazas is presenting imaging approach to focal liver lesions. I'm sure she will shed a good light on the diagnostic dilemma and the challenges of focal liver lesions and how to deal with it. I'm handing the platform to you, Dr. Terrazas.
Thank you. I'm Martha Terrazas, and I'm really happy to be here. And as you could see, the title of my talk is Imaging Approach to Liver Lesions in Non-Cirrhotic in non-cirrhotic livers. I am currently now, as Dr. Omar was saying, with the Cleveland Clinic, and my email address is here. So if anybody ever has questions, feel free to email me. And I usually give this lecture free, available. So if this could be emailed out, so people can have these lectures, and feel free to use these cases. All these cases were what I saw in fellowship. Okay, here we go. So the objectives of the talk. So the first objective is to know the MR characteristics to distinguish between benign liver lesions. So being able to understand what you're going to look for on MR to distinguish an adenoma from focal nodular hyperplasia, a hemangioma, an abscess, which can mimic cancer, right? And sometimes can look really concerning, but will have some distinctive features. Another benign lesion that we commonly see, but we don't actually think to ourselves, this is what this is a ciliated hepatic foregut cyst. Oh, there we go. And then know the MR characteristics to distinguish a hemangioma from metastasis and angiosarcoma. And the reason why I have one of these as an objective is because I have seen metastasis or angiosarcoma be confused with the hemangioma because they sometimes have some overlapping MR features. And to know the MR imaging features of cholangiocarcinoma, because this is something that is not uncommon, and you will see it. And to know the MR imaging features of the following uncommon malignant lesions. The first one is a really long name, malignant epithelioid hemangioendothelioma. And I saw a case of that in fellowship, and I thought it was really interesting because it had a very distinctive appearance. In fibrolamellar HCC, and I've only seen 2 cases of fibrolamellar HCC, one in fellowship and one as an attending, but also has very distinctive imaging features. So we'll get started with case 1. So this is a 23-year-old female that presents with vague abdominal pain, and she had 2 indeterminate liver lesions found on MRI. So both of these phases are our arterial phase, right? We have most of our contrast in our aorta. So our aorta is what's lighting up. So we see this liver lesion here in the hepatic, left hepatic lobe towards the dome. We have an arterially enhancing liver lesion there. And then centrally within the liver, we have another arterially enhancing liver lesion. So we have 2 arterially enhancing liver lesions right there and there. So what's our findings? 2 arterial enhancing liver lesions. So a differential diagnosis in a young female who does not have a history of cirrhosis or chronic hepatitis B infection. You're going to be thinking adenoma because adenomas are arterially enhancing lesions. And FNH, focal nodular hyperplasia. Those are the top 2 on your differential diagnosis in a young female without history of chronic hepatitis B or cirrhosis or a history of malignancy. Hepatocellular carcinoma would be in the differential if this patient did have chronic hepatitis B infection or cirrhosis, and metastasis in the setting of suspected malignancy. So this is our T2 haste. And here, where we know that one of our liver lesions is our arterial enhancing liver lesion, we look to see, do we see any signal on our T2 haste? And we actually don't. We don't see anything there to correspond with that arterial enhancement that we saw on an arterially enhancing sequence. So our T2 haste sequence demonstrates that these are what are called stealth lesions. And I think I finally understood that later on in residency. I'm like, well, okay, there's stealth on our T2 haste, and we don't actually see any signal where we would expect to see something because we have an arterially enhancing lesion. And this is an important imaging feature. So we see no corresponding signal identified on T2 weighted imaging. And so these lesions could be missed if we did this MRI without contrast. So if we didn't give arterial contrast, we might not even know that this patient had these liver lesions there. So now we're going to move on to our in and out of phase imaging, and I'm just going to move my thing here. We're going to move on to our in and out of phase imaging, so our out of phase and our in phase. So our out of phase, we know that this is our out of phase because it looks like it has an outline on all our organs, and then our in phase goes along with it. These are read together. This is an important set of sequences, because it tells us if there's a drop in signal on our out of phase by 15%, a drop of signal on out of phase, then there is microscopic or intracellular fat, not gross or macroscopic fat. This is microscopic fat, right? This is what you would see in hepatic steatosis. Or liver lesions that have microscopic fat. So we put an ROI where we expect that liver lesion to be, and then we localize it on the end phase. And there's actually, when you compare the ROIs, there's actually not a 15% drop in our ROI. So it does not have microscopic fat in it. So our findings, there is no signal dropout on our out of phase compared to in phase. So that would be characterized by 15% drop of signal on the out of phase compared to the in phase, which we don't have. So there is no intracellular or microscopic fat in this lesion. So this is important because some hepatic adenomas, particularly the HNF1 alpha subtype, these can have intracellular microscopic fat. This is an imaging feature of our HNF1 alpha subtype. So if we had microscopic fat, we might be thinking, hey, we're leaning towards this type of adenoma. So this study was actually performed with hepatobiliary specific contrast. And this is basically a very delayed phase, and it's a 20-minute delayed phase. And this contrast on the 20-minute delayed phase, functioning hepatocytes will retain this contrast. So we can see in both our liver lesions, our arterially enhancing liver lesions, we have some contrast retention in these lesions. So this is suggesting that this is of hepatocellular origin. So let's just a quick side note about hepatobiliary specific agents. Lesions without hepatobiliary function will not retain or accumulate the contrast on the 20-minute delayed phase. So for example, cysts, hemangiomas, adenomas, they don't have functioning hepatocytes. They're basically going to be black holes. They're not going to be holding on to that contrast. And why is this sequence helpful in this case, the 20-minute delayed hepatobiliary phase? And it's helpful because these lesions that are that retain hepatobiliary specific contrast on the 20-minute hepatobiliary phase, they tell you that they have some hepatocytes in them. And lesions that are not having functioning hepatocytes are hypodense or dark on that phase. So these lesions have the lesions that we're looking at have functioning hepatocytes. So I would, for testing purposes, when people would show me the people that write the tests would show me a sequence, and I'm like, is this a 20-minute delayed hepatobiliary specific phase? The way you can tell is the liver's really bright. There's one of our lesions. The liver's really bright, and there's their other lesion. And we actually have excretion of our contrast. So what we see is contrast being excreted into our biliary system. It's excreted into our gallbladder, our common bile duct, as we can see here. And so this also makes the hepatobiliary specific contrast agents helpful in identifying biliary leaks as well. But if you ever see contrast in the gallbladder or being excreted into the common bile duct, you know that you're dealing with a hepatobiliary specific agent. And the liver's really bright. So putting all this together, that we know of all the imaging features that we saw, this has to be focal nodular hyperplasia. So we have, just to recap, we have 2 arterially enhancing liver lesions, and we said this was an FNH versus adenoma in a patient without cirrhosis or chronic hepatitis B. There was no intracellular fat on our out of phase and in phase imaging to suggest that we're dealing more with an adenoma. And we got this exam with hepatobiliary specific contrast. So on the 20-minute hepatobiliary phase, it retained that contrast. So this is compatible with an FNH because it has functioning hepatocytes. So we feel confident that we could call this an FNH. bucconodular hyperplasia. So this is just an abnormal arrangement of normal hepatocytes, and it has dense fibrous tissue, malformed biliary drainage, a central scar. It can have, you don't always see it, you don't always have to. And these central scars are T2 hyperintense, so they're bright, and they have enhancement on post-contrast sequences. So on our T2 weighted images, they're going to be bright, and we'll have enhancement of that scar. They're the second most common benign liver lesion encountered. Hemangioma is number one, and they have a female predominance. About 10 to 20% only occur in males, and they can occur after chemotherapy. I've seen a couple of cases of that in fellowship, actually, and they had to biopsy it to show it because the patient had cancer and was on chemotherapy, and they had a new liver lesion, and then they biopsied it, and it was an FNH induced by chemotherapy. And approximately 80% of FNHs retain hepatobiliary specific contrast agent. So like everything in radiology, not every lesion is going to follow the book. And you can have atypical FNHs that can have intralesional microscopic fat to make you think it's an adenoma. Or they can have a pseudocapsule, which is maybe a more concerning feature that you're thinking you're dealing with, maybe not a benign lesion. And they can have non-enhancement of the central scar. But 80% of them will retain contrast with hepatobiliary specific agents. So case two, we have an arterial T1 fat saturation arterial phase. And we see that we have a liver lesion here in the inferior right hepatic lobe. So our findings, arterial enhancing lesion, and again, our differential is going to be an FNH. And then now that we know from case one, we would think to ourselves, do we need to repeat this study with a hepatobiliary specific contrast to make that diagnosis? Would be thinking of an adenoma. We want to look for intracellular fat or T1 hyperintensity from bleeding. So as we talked about in case one, if we have intracellular fat on our out of phase and in phase imaging, this leans towards the HNF1 alpha subtype adenoma. And we also know that adenomas bleed. So the sequence, the MR sequence for that to show that something is bleeding or it has bled is your T1 pre-contrast imaging. That if it's bright on there, there's not many things that are bright on our T1 weighted images. One of them is blood. And so you would look at that sequence to see if this lesion is bleeding. And of course, metastases and HCC in the setting of cirrhosis or chronic hepatitis B infection. So here we have our out of phase and our in phase imaging, and we put ROIs on there. And I put the ROI numbers on there, but we indeed visually, so qualitatively, we do look like we have a drop of signal on our in phase compared to our out of phase. And quantitatively, we actually put our ROIs on there and show that there is a 15% drop. So we have focal dropout of signal in our out of phase compared to in phase, more than 15%. So this lesion does have microscopic fat. These findings are compatible with intracellular microscopic fat. So this has to be an adenoma, right? So putting it together, we have an arterially enhancing lesion here in the inferior right hepatic lobe. And there is intracellular fat. So we're thinking this is an adenoma, specifically the HNF1 alpha subtype. So there's three different subtypes of adenomas. And for the inflammatory subtype, these are the most common, and these have the highest bleed rate. So these are usually our young patients that come into the emergency department with right upper quadrant abdominal pain. You get a CT and they're bleeding around the liver and they have a bleeding liver lesion. So again, your sequence that's going to help you with that is your T1 sequence, because they're T1 hyperintense hemorrhage, and they can have heterogeneous signal on T2, but that T1 pre-image is your most important. This subtype can retain hepatobiliary specific contrast on our 20-minute hepatobiliary phase imaging. So this is when it can be confused with an FNH. And in those cases, you kind of just have to, in that case, it might just be a differential, or you might lean more towards, you might lean to an adenoma because FNHs don't bleed. So, and then the HNF1 alpha mutated subtype, these are the second most common. They're often multiple. These are females that are on birth control pills. And these are the lesions that have intracellular fat. So you think about MRI, we have all these sequences, right? Sometimes you get sequence fatigue because there's so many different sequences. But when you think of adenomas, you go, oh, the inflammatory subtype, these ones bleed. I'm going to look at my T1 pre-contrast because if it's bright on there, that is suggesting bleeding. And this is probably an inflammatory adenoma because I know FNHs don't bleed. And then if it has intracellular fat, you're thinking the HNF1 alpha subtype. And then we have the beta-catenin mutated. These are the least common. These are the ones that we would see in men taking anabolic steroids or in patients that have glycogen storage disease. And these are the lesions that really don't have any specific MRI sequence imaging features. And so these ones are harder to diagnose, and these have the highest rate of malignant transformation to HCC. So here we have a case of, let me move this. This is a 32-year-old female, history of thyroid cancer. And she came in, and what we see here is we have hyperdense ascites around the liver. So we're thinking she's bleeding. We have hemorrhagic ascites. We have this large liver lesion in the inferior right hepatic lobe that looks like that's the source of bleeding. And the bleeding's extending along the pericolic gutters into the pelvis. And we have some small foci there that looks like it's very bright, so active bleeding in this lesion. So bleeding liver lesion in a young patient. And she also has a history of thyroid cancer. So we recommended an MRI. We were thinking this is likely a bleeding adenoma, but we wanted to prove it. So this is what we're talking about here on our T1 fat saturation pre, no contrast, right? It is very bright. This lesion is bright. It has a lot of T1 hyperintensity associated with it because it's bleeding. And we know that from the CT. Then we get the T1 fat saturation arterial, and visually just looking at the arterial compared to the pre, it doesn't look like it's enhancing. We did put ROIs on it to prove that it wasn't enhancing. And we got subtraction images where you subtract the pre and the post to prove that it's not enhancing. Then we come here to our out of phase and our in phase to see, does this have intracellular or microscopic fat? And it doesn't, right? Visually, it looks the same. There's no change in ROI here. And just to show you these subtraction images, there was no enhancement in this lesion. What you see here in the periphery is just noise. This lesion is not arterially enhancing. So because we didn't really have, besides the T1 hyperintensity that showed us that it was bleeding, which we saw from the CT, we didn't really have the diagnosis. But we did know it's T1 hyperintense compatible with hemorrhage seen on CT, no arterial enhancement, and that was confirmed with subtraction images, and no intracellular or microscopic fat. So this actually, because of the history of thyroid cancer, this actually went to PET CT, and we see that this liver lesion here, it was not FDG avid, and then it went to biopsy because given the history of thyroid cancer, we just wanted to make sure that we were not dealing with a bleeding malignancy. And then they're biopsying it there by interventional radiology. So the pathology results, it actually came back as hepatocellular adenoma. So it was an adenoma, but not otherwise specified. And the comment was this lesion is most compatible with an adenoma. And it just, even though we didn't have the arterial enhancement, if it had the arterial enhancement, it was bleeding, we would probably be like, oh yeah, this is an adenoma. But the fact that she had thyroid cancer, we were a little bit nervous and just wanted to make sure that we weren't dealing with the bleeding malignancy. But this case actually did have features of the inflammatory subtype adenomas. So case 4, 46-year-old female, and we have a follow-up MR for a lesion identified on ultrasound. So here is, this was a very interesting case that I saw in fellowship. This is a T2 haste 4 years ago. So we have this small lesion here. It's T2 hyperintense, right? So we know that this is a T2 weighted sequence. T2O, I think like H2O is water, T2O, so water is bright. So we have this little lesion here that they thought was really bright. So they actually called it a cyst and moved on. So now, fast forward 4 years later, this patient comes back with this lesion is enlarging. So we're dealing with, so this is our T2 weighted sequence with fat saturation. So it's same thing like the HACE, but the fat is taken out, right? So it basically brings out lesions that have T2 hyperintensity. So this lesion, this central component that is T2 bright, seems like it got bigger. And now it has this heterogeneous T2 surrounding component. And then here is our B weighted imaging. So this is our diffusion weighted imaging. So we look at our highest B weighted value, and in body, it's typically B800 sequence or DWI, and that we read it with our ADC map, kind of like we read the in phase and out of phase together. We read our diffusion weighted imaging with our ADC map. So things that are bright on our DWI, high B weighted value imaging, and if they're corresponding dark on our ADC map, that suggests restricted diffusion. That just means that there's hypercellularity within this lesion. So here we see that the surrounding stuff here is sort of bright compared to the adjacent liver, and it is dark on our ADC map. So that's suggesting that there is restricted diffusion. So now we have our T1 fat saturation pre, and then our post-contrast, our arterial portovenous equilibrium. And we actually have here, we look, the liver's really bright, and we have excretion of contrast into our biliary system. So we know that this is a hepatobiliary specific contrast agent. So we have a heterogeneously arterially enhancing lesion that continues to enhance on post-contrast imaging, and it does not retain any contrast. It's black on the hepatobiliary face. And whatever the central thing here that was bright, we could see here, 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 and we see it on all these sequences. So our findings: heterogeneous T2 hyperintense lesion, it increased in size from 4 years prior. It's T1 heterogeneous. Yes, let me show you that because I kind of skipped over that. We see that this lesion here, it's not dark on our T1 fat saturation pre. We actually do see that it's a little bright compared to the adjacent liver. It's sort of like the same intensity, maybe a little bit brighter in some areas. So it's T1 heterogeneous. It does have arterial enhancement, and it has persistent delayed enhancement that we saw as we were going on, and no retention of contrast on our 20-minute hepatobiliary phase imaging. So for this lesion, what would our differential diagnosis be? Could this be an atypical FNH that isn't retaining hepatobiliary specific contrast agent, maybe because it has a non-enhancing central scar that is T2 hyperintense? Could this be an adenoma? Could it be an inflammatory subtype adenoma given its T1 hyperintensity? Maybe it does have a little bit of bleeding in it, or it had some bleeding in it. Or could this be a fibrolamellar HCC? That was actually thought of in this case because for fibrolamellar HCCs, you think, is this a non-enhancing scar? And that is an imaging feature for that. And so that was something that was also in the back of our mind. So this, because we didn't know, and we had that differential, it went for biopsy, and they did a partial hepatectomy, and it came back as a hepatic adenoma, but it came back as a hepatic adenoma telangiectatic type. And I had never heard of that. So I had to Google it. So these were previously called telangiectatic focal nodular hyperplasias to just confuse it all more. And the classification actually changed based on molecular and genetic evidence. It has a female to male predominance. And these actually have potential for malignancy because these are different than the adenomas that we just saw. These are different than their HNF1 alphas or inflammatory subtypes because these behave neoplastic rather than regenerative. And treatment is actually surgery, and she did have a partial hepatectomy, so she got that out. So MRI findings, this was actually published in a paper, and this is when we went back and looked at our case, we were like, wow, we have this on our case. Strongly T2 hyperintense, we had that central component that was very, very, very bright, almost looked cystic, right? Very strongly T2 hyperintense centrally. Has some T1 hyperintensity in it, right? It's not dark. Like centrally here, this would be no T1 hyperintensity. So this does have some T1 hyperintensity associated with it. And it has persistent delayed enhancement, and that is thought maybe from sinusoidal dilation. So be careful with arterially enhancing hepatic lesions. So if we have an arterially enhancing lesion, make sure this patient doesn't have cirrhosis or chronic hepatitis B infection, right? Make sure we're not looking at hepatocellular carcinoma. And the reason why is because hepatocellular carcinomas mimic all these lesions. Hepatocellular carcinomas can have intracellular fat, and they can bleed like adenomas. And while differentiated hepatocellular carcinomas can actually retain hepatobiliary specific contrast agent on our 20-minute hepatobiliary phase imaging. So they can mimic FNHs. So case 5, we have our T2 haste here. We have this very T2 hyperintense lesion in the right hepatic lobe. We go to our arterial phase and delayed phase imaging. On our arterial phase, we have peripheral, nodular, discontinuous enhancement, right? Some enhancement here, it's a little nodular, and some enhancement here, it's a little nodular, but it's not ring or rim enhancement, right? It's discontinuous. And then on our delayed phase imaging, this lesion fills in, it increases enhancement. So findings, the most important feature is that this is a T2 hyperintense lesion. Peripheral nodular discontinuous enhancement, and enhancement increases with delayed phase imaging. So what is this? We would say this all day, every day. We know what this is. We could say this in our sleep. This is the hemangioma, right? So the reason why I show this, though, is because to recap what makes a hemangioma, the features important for hemangiomas. The most important feature is T2 hyperintensity. And this was what was taught to me in fellowship by my fellowship director is if you have a lesion that does not, that you think may be a hemangioma on your post-contrast imaging, right? Nodular discontinuous enhancement, but it doesn't have T2 hyperintensity, you cannot reliably call it a hemangioma. Now, it could be a sclerosing hemangioma, but you still wouldn't make the diagnosis hemangioma and move on and be done with the case if it didn't have T2 hyperintensity to it. And these will not retain hepatobiliary specific contrast agent on the 20-minute hepatobiliary phase imaging because they have no hepatocytes. And they will not spontaneously bleed like adenomas in a patient without cirrhosis or chronic hepatitis B. And they don't spontaneously bleed like patients with HCC in a cirrhotic or chronic hepatitis B patient. So case 6, 50-year-old female, history of decompensated cirrhosis. So we have our pre and our arterial, portovenous, and post-contrast imaging, delayed equilibrium phases. So here on our pre, we see that we have this dark lesion in the peripheral right hepatic lobe. And you start to look at the post-contrast imaging, and it sort of has arterial nodular discontinuous enhancement, right? And on our portovenous phase, nodular discontinuous enhancement that increases on delayed phase imaging. So maybe if you were to see that image, just the post-contrast images, sequences, you might think, could this be a hemangioma? Well, what is the most important sequence is, does it have some T2 hyperintensity to it? So here's our liver lesion. Maybe it has some capsular retraction. Is it T2 hyperintense? Well, has some signal in it on our T2 weighted fat saturation images, but it's not as bright as adjacent fluid, right? So she has some ascites here that we can compare it to, and it's not as bright as that. So this doesn't have the T2 hyperintensity associated with the hemangioma. We come to our ADC map, our high B weighted value images compared to our ADC map. It's not bright on our DWI and it's not dark on our ADC map. So it doesn't have restricted diffusion. And we come to our in and out of phase imaging and just putting ROIs on it and looking visually, it doesn't have microscopic or intracellular fat. So this does have peripheral nodular enhancement, progressive filling on delayed phase imaging, heterogeneous T1 and T2 signal, but it's not T2 hyperintense like hemangiomas. So our differential diagnosis, because this is a cirrhotic patient, could this be an atypical HCC given the patient's cirrhosis? Could this be cholangiocarcinoma because we did maybe have some overlying capsular retraction? Or could this be angiosarcoma? or an atypical hemangioma. An atypical hemangioma, which would be like a sclerosing hemangioma, would be a diagnosis of exclusion. That would be like, we biopsied this lesion and that's what it came as. So this actually came back as a low-grade angiosarcoma. I saw this case in fellowship, and I really like it because it looks like a hemangioma to me on our post-contrast images. And the features of it make it look like a hemangioma, except it doesn't have that important imaging feature of being T2 hyperintense. So these are very rare. It's not like we see these all the time. Only 1% of all primary liver tumors. And metastases are common in the lung and spleen. And they have a poor prognosis. And imaging characteristics, T2 and T1 heterogeneous, which we saw, and it's due to solid and hemorrhagic components. And post-contrast imaging is peripheral nodular enhancement with progressive filling. So if something looks very heterogeneous on your T2 and your T1, but has that peripheral nodular enhancement with progressive filling on your delayed phase imaging, and you're thinking angiosarcoma in this case. So case 7. Here we have this infiltrative mass on our we could see it. This infiltrative mass in the left hepatic lobe, and we have some capsular retraction. On our T2 fat saturation, this is very helpful because, yes, we see that we have this mass here. But what's very helpful here is we actually see that there's dilated biliary, intrahepatic biliary ducts within this infiltrative mass. And our T2 haste, and then our coronal sorry, let me move this. On our coronal T2 haste, we see, okay, we have this biliary dilation here at the level of the mass. There we go. So we go to our ADC map and our high B weighted value imaging, B800, and we see that's very bright on our B800, and it has the corresponding dark signal on our ADC map. So this mass has marked restricted diffusion. If you look at this, and also I'll give anybody this lecture, but if you look at this set of images and you compare it to the angiosarcoma, you see that, hey, this actually has marked restricted diffusion. This is what marked restricted diffusion looks like, and the other one had no restricted diffusion. There was no difference between the ADC map and our DWI. So let's look at our contrast enhancement. This is our arterial, portovenous, and delayed phase imaging. So what do we have here? So we have our left hepatic lobe infiltrative mass. We have arterial enhancement, but this enhancement increases on delayed phase imaging. So this is cholangiocarcinoma, and this case actually has the features of cholangiocarcinoma. So we have an enhancing hepatic mass, and it has some overlying capsular retraction, and they may have associated intrahepatic biliary dilation, which we had in this case. And there is increased enhancement on delayed phase imaging. You can also see cholangiocarcinoma in the setting of cirrhosis, and you can also have mixed hepatocellular carcinoma and cholangiocarcinoma, which I have seen. And these are what we call LIRADS-M lesions in cirrhotic patients. These usually need a biopsy to make the diagnosis. So case 8. This is a 23-year-old male. He had a 1-month history of jaundice and epigastric pain, 15-pound weight loss, no history of cirrhosis or chronic hepatitis B infection. So on our T2 fat sat here in the left hepatic lobe, we do see an infiltrative liver lesion here. We do see that there is biliary dilation. And our coronal shows that we have this infiltrative mass here, probably extending into our hilum here of our liver, and we do have biliary dilation. On our high B weighted value imaging and our ADC map, there is restricted diffusion, not as marked as the last case, but it is bright on our B800 and it is dark on our ADC map. So now we come to our pre-contrast images, our T1 fat saturation pre, and then our T1 arterial, portovenous, equilibrium, and delayed phase. So we do see that there is some enhancement on the arterial phase, and we have increased, it continues to have enhancement on delayed phase images within this lesion. One thing that was noted in this lesion was here centrally within the liver, we were wondering, are we dealing with something that's not enhancing? Is that a bile duct? Is there something centrally here within this liver that's not enhancing? We're like, is it a bile duct? Is it a central scar? So there's heterogeneous arterial enhancement, and there is delayed iso enhancement compared to the adjacent liver. And we were wondering, is there a non-enhancing central scar? Because there was this persistent area centrally that wasn't enhancing. So differential diagnosis would be fibrolamellar HCC, metastases, right? I've seen metastases look like, just like many of you probably have seen it look like anything. I mean, I've seen metastases look like cholangiocarcinoma. Could this be a large atypical hemangioma or an FNH or an adenoma? Most likely not, right? Because this has infiltrative features with biliary dilation. So we actually had a PET CT and it was FDG avid. And this turned out to be hyperlamellar HCC. So these are younger patients. I've only seen maybe 2 cases. This turned out to be fibrolamellar HCC, and younger patients, we see them in 20 to 40-year-olds. They're not associated with cirrhosis or chronic hepatitis B infection because I used to think, oh, it's HCC. So it should probably be associated with that, but it's not. It does have a central scar, and in the literature, I mean, it's quoted from, you can see a central scar from anywhere from 20 to 71% of cases. So it's all over the place. And they usually have significant lymphadenopathy is seen in more than 50% of the cases. And on CT, we kind of see the same thing. We have a central scar because of that dense fibrotic band, and it can have calcifications. And on MRI, we see a heterogeneous arterial enhancement, which we had here, and delayed iso enhancement, or can even have washout. Oops, sorry. And the central scar is usually hypo-intense on all sequences. And maybe that's just because it's like fibrotic bands that don't really enhance. Okay, here, case 9. This is a 71-year-old male with a history of liver failure and cirrhosis, jaundice, and weight loss. So here we have our pre and our post-contrast arterial and delayed phase images. So first off, we see that this liver is very lumpy bumpy, right? There's many contour abnormalities here. And on arterial phase, we see all these these lesions with peripheral arterial enhancement in the subcapsular or peripheral region of the liver. And these lesions sort of increase enhancement on more delayed phase imaging. Here we come to our T2 haste, and it does have some T2 hyperintensity associated with these lesions. And then on our DWI, they are bright, and there are maybe a little dark on our ADC map. So heterogeneous T2 signal, multiple subcapsular lesions with peripheral arterial enhancement and restricted diffusion. So could we be dealing with cholangiocarcinoma in this case for differential, given that there's overlying capsular retraction, HCC, given history of cirrhosis, right? So they biopsy these because these actually don't fit HCC in terms of they could most definitely be atypical HCCs or what we'd call LIRADS M. They could be cholangiocarcinoma, so they had to biopsy it, and it came back as malignant epithelioid hemangioendothelioma. These have a male predominance. You see them in ages 30 to 50 years old. And the CT findings are very similar, multiple peripheral masses, subcapsular in location, that's what we had. Can have capsular retraction and mimic cholangiocarcinoma. And they can have hypoenhancement or heterogeneous enhancement. But what you see is characteristic, they're peripheral, subcapsular, and they have that target pattern or halo pattern of enhancement. On MRI, same thing, T2, heterogeneous to hyperintense. And on our contrast-weighted images, we see peripheral enhancement or target-like enhancement, like we saw in this case. And I'm sorry, I know I'm running short on time, so I'm trying to get through these cases, and I'm sorry if I'm going a little fast. Case 10. So we had this patient that has this complex liver lesion in the right hepatic lobe, multiple septations, right? We have this lesion here, and here's our pre. So complex T2 hyperintense cystic lesion, right? We know it's cystic because on our T2 weighted images, it is bright fluid in there, but multiple septations. On our post-contrast enhancement delayed phase, we see that these septations are enhancing. And on our DWI, we see, hey, it's pretty bright on our high B weighted value images and dark on our ADC map. It has restricted diffusion. So enhancing septations, but no enhancing nodular tissue, right? It's just kind of those septations we're enhancing, and it has marked restricted diffusion. This came back as we knew this was an abscess. Because additional history of an appendicitis. And the reason why I show this case is because don't let the marked restricted diffusion confuse you into thinking that it is tumor or a solid lesion, because marked restricted diffusion can also be seen in infection and abscess and not always tumor. So next case, history of breast cancer. We have this lesion here in the right hepatic lobe. Centrally, it has this bright T2 hyperintense component, but when you look at the T2 haze, it has this it's actually pretty heterogeneous T2 hyperintense. History of breast cancer, remember. So our pre and our post contrast images, we see that this actually has ring or rim enhancement around the lesion. And to show our ADC map and our high B weighted value images, there's actually no restricted diffusion within this lesion. So these lesions are most consistent with metastasis, period, because she has a history of breast cancer and we have ring or rim enhancement. They do not have features of a hemangioma, right? They're very heterogeneous on T2. They're not just a T2 hyperintense lesion that looks like a cyst. And the path showed metastatic adenocarcinoma consistent with breast primary. So this is just a summary of what we talked about. Hepatic metastases, they can be hypervascular metastases and show early continuous enhancing ring, which we saw here. This is when it can be confused with a hemangioma. That last case I showed you was actually called a hemangioma. And larger lesions can show rim enhancement and washout. That's going to help you distinguish it from a hemangioma. So hepatic hemangiomas are T2 hyperintense. They look like cysts. And then you see the post-contrast imaging and you see the peripheral nodular discontinuous enhancement. And they're hyperintense actually on our DWI weighted sequences, and which can be due to blood flow, and they can have mixed intensity on our ADC. So actually your DWI and your ADC does not help you with hemangiomas. It's really your T2 weighted images and then your post-contrast. Here, case 12, we have a T2 hyperintense lesion, and this is going to be ciliated hepatic foregut cyst. And the reason is this is T2 hyperintense lesion, looks like a cyst, right? But it's a cystic lesion in a specific location of the liver. So location, location, location. I see these all the time. I do emergency imaging, overnight imaging, and I see these not infrequently. And so these are subcapsular location, segment 4 of the liver. They're solitary, non-enhancing, benign, very small malignant potential reported in the literature, but this is just based on location. And then this is just the recap, liver lesions recap. If you have arterially enhancing liver lesions, you got to make sure you're not dealing with a cirrhotic or chronic hepatitis B patient. If you're not, you want to look for intracellular fat or T1 hyperintensity, because if it has intracellular fat, like we saw, it can be an adenoma. If it's bleeding, it can be an adenoma. If you get a 20-minute hepatobiliary phase and it retains contrast, like the case that we saw, we know that we're dealing with an FNH. Does the patient have cirrhosis or chronic hepatitis B? Well, then now we're concerned we're dealing with hepatocellular carcinoma, because hepatocellular carcinomas can have intracellular fat. They can have T1 hyperintensity because they're bleeding. They can have, and they have washout in capsule, like in this case here, as for a lesion. And we know that we're dealing with HCHC. So hemangiomas, T2 hyperintense, peripheral nodular discontinuous enhancement, increases with delayed phase imaging. Most important feature, T2 hyperintense, as we saw in this case. T2 hyperintense. If you don't have that, you can't call it. Metastases, hypervascular, as we saw in the breast cancer patient. They can have rim or ring enhancement, heterogeneous T2 hyperintensity, right? This T2 signal is a lot different than the hemangioma. It's not as bright. Angiosarcoma, heterogeneous T1 signal due to hemorrhage and soft tissue, but these kind of look like hemangiomas on our post-contrast imaging, peripheral nodular enhancement, and they with progressive filling. And then the last page, cholangiocarcinoma, they're going to have capsular retraction, biliary dilation, which you're going to see on your T2 weighted images, and delayed enhancement. And the one that's very rare, but is if you see it, it's kind of like, oh, I've seen something like this before because it's very unique. Malignant epithelioid hemangioendothelioma. So these are multiple peripheral lesions, subcapsular. They have that capsular retraction and they have that target or peripheral enhancement. And these are my references. And I am done. Thank you so much. I'm sorry. The last case is, I just wanted to make sure that we had time for questions, but all my cases are from Northwestern Memorial Hospital, where I did my fellowship, and the University of New Mexico, where I wasn't attending.
Well, thank you, Dr. Perez. Interesting cases and interesting Actually, I liked what you did with the patient of the telangiectatic adenoma, and that the fact that the liver is always wowing you and astonishing you every time, because it's full of lesions that you wouldn't know what is them until you have the biopsy back. So it's always have something new, no matter how senior or no matter how radiology or hepatobiliary, it will always astonish you. We'll go for the questions. Actually, there are a few questions here. One of the attendees is asking, please simply expand on diffusion restriction and dual echo imaging in liver disease.
I'm sorry, can you repeat that? I had a hard time hearing.
She is asking, please simply expand on diffusion restriction. I think they are asking about the diffusion restriction related to lesions and dual echo imaging in liver disease.
Okay, yes. So let me come here I can show some. When I started learning MRI from my in fellowship, I learned it with Frank Miller at Northwestern. And basically, what I would ask him to do, I'm trying to come to my cholangiocarcinoma case here. I would tell him, please show me very characteristic imaging features of lesions on sequences. So I would say, show me classic restricted diffusion. So when you get restricted diffusion, when you get your B weighted value, when you get your B weighted value images, we would usually get our B200 or B500 and our B800. And then our B800 is what we would call our high diffusion weighted images. And so that's what we use in body, B800. In prostate, we use like B1200. And in body, we use the B800. So you would have to find a B800 sequences. And then you pull up an ADC map, and basically those are read together, because things that are very bright, like assist can sometimes assist, you might actually still see on our B800 sequence because it has just bright signal, but they don't have the dark signal on our ADC map. And I don't understand the physics behind it. Like, that stuff has left my mind a long time ago in fellowship. But if it was something like a cyst that was continuously bright on our B800 images, and then they were bright on our ADC map, that shows that it doesn't have restricted diffusion. So you want it to be bright on our ADC map, or I mean, bright on our high B weighted value images and dark on our ADC map to have restricted diffusion. And not all that means is that it is hypercellular tissue. So abscess can have restricted diffusion, so infection, and tumor can have restricted diffusion. And so not everything, though, that does have restricted diffusion, not everything that has restricted diffusion is solid or a lesion. I don't know if I answered your question.
Yes, it's nice. And adding to that is that diffusion itself sometimes is deceiving. Sometimes we see malignant tumors, just like you just showed us, the angiosarcoma. It's a malignant tumor, and yet it's not having any diffusion restriction. And,
oh, yeah.
to be honest, diffusion is really deceiving all the time, even in the setting of cirrhosis and HCC. Sometimes we see some nodules that are not arterially enhancing, and then yet you will find some restriction in them. And I don't know, but at our institution, we take the restriction for diffusion as an early predictor for HCC, for early prediction of turnover of this plastic nodule into an HCC, even if it's not having the arterial enhancing. So, as you said, the physics beyond it is so complex, and even the fundamentals of which is more cellular and which is more fluidish is really deceiving.
Yeah, absolutely. So, restricted diffusion isn't, I show it just because it's the sequence that I do look at. But if I do think something's malignant and it doesn't have restricted diffusion, I don't let that sway me. And yeah, absolutely. In patients with cirrhosis, restricted diffusion can be an ancillary feature, even though, yeah, they're not looking like a hepatocellular carcinoma. Maybe they don't have the arterial enhancement. Maybe they don't have washout. But if they have restricted diffusion, that can be a feature of it can be an ancillary feature that you can use in your LIRADs. So they did incorporate it that way, but yeah, it's not helpful in nailing a diagnosis.
Yeah, sometimes it's more puzzling, actually.
Yeah, absolutely.
We're having another attendee asking, obviously they are very amazed with your session and they are thanking you a lot. So they are asking, what about melanoma metastasis?
So melanoma is one of the, as I was saying, on our T1 pre-saturation images, there's not many things that are T1 bright. That's why I like it when I see like some signal on T1, because I'm like, oh, there's like not a list of things, right? It's hemorrhage or melanin. So melanin can have be bright on our T1 pre-images. So I actually just saw a case of, they asked about melanoma, right? Yeah, okay. I saw a case of in the ER, a patient had got an MRI because it was they had got an MRCP because they thought they had choledochal lithiasis, and this patient had a history of melanoma, and in the gallbladder, along the gallbladder wall, there was like these nodules, and they were very, very T1 bright. And it was metastasis from the melanoma in the gallbladder wall, which was sort of random. And I didn't really appreciate it on any other sequences except my T1 when I saw, hey, there is some nodularity in the wall here, and he has a lot of nodularity, and it's T1 bright, and it was melanin from his melanoma.
Wow. Wow. They know in the liver itself.
In the liver itself, yeah, and it's the same thing. If you have it's going to be T1 anywhere. If you have melanoma in the liver, I mean, in terms of contrast enhancement, I guess I don't really. I'm assuming that it would just be some enhancement. Maybe it doesn't have a lot of enhancement. Maybe it does have some enhancement, but I think that what would clinch the diagnosis would be our T1 pre. You would just see multiple lesions in the liver that have T1 hyperintensity with them.
That's true. Okay, we're having another attendees asking, can you share your experience with inflammatory hepatic pseudotumor? Inflammatory hepatic pseudotumor.
Oh, I'm sorry, you're cutting off a little bit. Did you say inflammatory pseudotumor?
Yes, asking about inflammatory pseudotumor. Can you share your experience with inflammatory liver pseudotumor?
I'm so sorry. I think you're cutting off a little bit. I think I'm losing service because I couldn't hear what you said.
Yes,
Are
about
I'm sorry.
inflammatory hepatic tumor.
Yes, Dr. Omar says, can you share your experience with inflammatory hepatic pseudotumor?
Oh, okay, got it. Yeah, sorry about that. I think I was just cutting off a little bit. Honestly, I haven't seen too many of them. In terms of, I think maybe the last time and honestly, I don't even know if I've seen one in residency. I know that they can mimic malignancy, but I can't really expand too much on it because I haven't seen them. I'm trying to think if I saw one in residency or in fellowship.
Okay. So is asking,
Was that the last question?
can you hear me now?
I
Am
think
I
that,
cut off or you can hear me now, Dr. Teresa?
yes, I think it's just cutting in and out.
Oh,
I know. It was
okay.
working just great earlier.
Oh, yeah, it was going nicely. So we're getting to our last question. Someone is asking, can cholangiocarcinomas have venous and delayed washout with intraductal excisions and validations? Should I consider CC with validation or cholangiocarcinoma presentations?
I'm sorry, Dr. Trepani, did you get some of that? I'm still
Yes,
cutting out.
Dr. Omar, the internet may, we will have problem about the internet. So the last question from attendee is, cholangioma, can cholangiocarcinoma have portal venous phase washouts?
Yeah. So cholangiocarcinoma, definitely the characteristic of it would be that we do have increased enhancement on delayed phase imaging. So that would be when you have the capsular retraction, heterogeneously arterial enhancing lesion, and then increased enhancement on delayed phase imaging. And then you're like, oh, thank you. This is a cholangiocarcinoma. It's following the book. But yeah, cholangiocarcinomas, they can behave differently, and they can have what looks like washout, and especially in a cirrhotic patient, that's just going to confuse the picture. And sometimes these lesions just have to be they may have to be biopsied, and then that would come back and you'd be like, oh, it was a cholangiocarcinoma, and because it didn't have the classic imaging features. So yeah, they could definitely have different type of enhancement patterns.
So if that is the case, should we consider the same findings as hepatocellular carcinoma with intraductal extension, or just cholangiocarcinoma? What is your
um,
different diagnosis?
yeah. And if we're certain, absolutely, you could consider that if the patient has a history of chronic hepatitis B infection or chronic hepatitis B infection or cirrhosis, then you would definitely think, could this be cholangiocarcinoma and a mixed hepatocellular carcinoma subtype? Absolutely. And then you would have to biopsy it. If you knew for certain this patient did not have cirrhosis and they did not have a chronic hepatitis B infection, you wouldn't think it would be HCC because those only occur in that population. And you would have to biopsy it. I've seen metastases look like cholangiocarcinomas, and I've seen metastases be big and confluent and infiltrative, and have some features of cholangiocarcinoma, and then we get the biopsy and it's a metastasis, like a colorectal metastasis. So yeah, sometimes when it's not straightforward, you may just have to go to biopsy.
Dr. Omar, I apologize because we could
It's
not
okay.
hear you.
I hope you're hearing me well now.
Yes, yes, I hear you now. I'm gonna pass this on to you. I will shut up.
No, please not, don't. So I think so I close it so I can enhance the voice. Uh, no more from the audience and these, and I was used uh, a dilemma for us. No matter how senior or no matter how, it's still challenging. Whenever you be holding the problem, as you said, don't hold there. So
Dr. Omar, your voice are very broken, and we could not catch. We could not catch. We could not get the. Yes.
Okay, no more questions there. I would say that you for the lecture, and I'm having a platform for you next.
JP, can you help? Are you there?
Sure. Yes. Yes, Nat. Hey.
Dr. Omar, a little
Yeah.
bit out the signal, so we could not hear her.
Correct. I think was this the last question we I mean, it's a great lecture, Dr.
Yes, that was
Martha.
the
It's a
last
great
question.
lecture. Yeah.
Thank you.
I think we should be good with the Q&A sessions now. We've just to be respectful of the time.
All right. So if that is the case, we're gonna go over, and Dr. Teresa and Dr. Omar, please feel free to leave or to stay. So we're gonna do the survey, and we're gonna do quiz question from now.
Thank you so much. I appreciate it.
Thank you, Mother. Thank you, Dr. Omar. And Dr. Ponatapura, you can share your screen for a quiz question.
Sure. Thank you. Hey, hello, everyone. That was a great lecture by Dr. Martha. I mean, amazing, very illustrative to show all the focal liver lesions, especially non-cirrhotic, but also she covered a lot of cholangio and then HCC. So great. So you guys, I expect you guys to just crush these questions. Let me share my screen, please. It's kind of a straightforward question. All right, I hope you guys can see my screen and listen to what I say. So on the leftmost here is the QR code. Please scan the QR code for you guys to look at the answer options. And the question is, what is the diagnosis the below case here? So see, the first image is a T2 fat SAT sequences. I mean, this is all about liver, so I'm not asking anything other than liver. It's going to be all about liver. T2 sequence, and the second one up here is the DWI sequence. The bottom image, just the far left, is the arterial phase, post T1 Gato-West arterial phase. And the middle image in the bottom is the venous phase. And the bottom image on the right is the delayed post-contrast images. So your time starts now. You have 3 minutes to answer this question. Please scan the QR code and you'll get the options. Option A is FNH, which is focal nodular hyperplasia. Option B is hepatocellular carcinoma. Option C is hemangioma. And option D is metastasis. What is the diagnosis? You have T2 sequence DWI, early arterial, followed by venous and delayed post-contrast studies. Images of MR. Option A is FNH. Option B is hepatocellular carcinoma. Option C is hemangioma. And option D is metastasis. You still have 2 more minutes.
We give you some more time. Initially, we planned for 1 minute, but some places have very slow internet. So to be fair with everyone, so that's why we increase it. We increase it to 3 minutes. Just let you know why we give you 3 minutes polling time. One more minute left. Thirty seconds.
30 seconds, correct. Another 30 seconds. Again, what is the diagnosis? Option A is FNH, B is HCC, C is hemangioma, and D is metastasis. All right, 15 more seconds. Last 5 seconds. Please submit the answers. Scan the QR codes and submit the answers. Thank you. All right. Great. So the answer for this question, okay, we're going to stop the pooling right now. If you want to submit, the last chance to submit the answers, the answer is HCC. B, hepatocellular carcinoma. I'm just going to go through this. T2 sequence, you see a nice lesion in segment 6 of the right lobe of the liver right there. T2 bright and DWI is bright. I don't have the ADC image, but it showed restriction diffusion. But the important sequence here is post contrast T1 arterial. You see how there is a non-REM arterial, early arterial enhancement. That's classic of HCC, which you see in LIRATs. Nice enhancement followed by a washout. You see the venous phase and you see a pseudocapsular enhancement right there. So again, be very mindful when you say washout. The washout has to be more than the liver parenchyma. You see nice washout right there on the venous and the delayed phase. So early arterial, non-REM arterial enhancement with a pseudocapsule, washout, all this restriction diffusion, T2 bright, classic of HCC. So so these are classic again based on the size. All these features are classic for a LIRATS phi. You always have to know about the LIRATS. So this is what a LIRATS here is. This is adopted from the ACR 2018 guidelines on hepatocellular carcinoma LIRATS. So that would be a LIRATS phi would not require a biopsy. It should be directly treated if it's a LIRATS phi lesion. And also I found this article on radiographics very useful, how to use LIRATs to report liver CT and MRI observations. This is an article by Kunha, which was published in 2021. Please refer to this article. Thank you so much. Back to you, Nat.
Yes, thank you. The IT team will bring up the photos of the price for May and also the QR code for us to evaluate the program. If you want to get at the next event, so our next event, this flyer is from our steering committee, is Dr. Kilanos from University of California, San Francisco, UCSF. So she will give us the pulmonary manifestations of connective tissue disease and vasculitis. So it is for the third Sunday of May, which is the 19th, and at the same time. And this is the QR code for evaluation. Anyone wants the certification of attendance, please give us some feedback here. And if you have a problem with the YouTube live that we have recorded lectures, contact this email research.sililat@gmail.com. Anything else, JP?
I think we should be good. It's all a great session, great education session today.
Okay.
Yep. Thank
All
you.
right. So we are done for today. Thank you everyone for joining us today, and we hope to see you next week. For radiology residents, I will see you next Sunday. It will be a body imaging case conference.
Nice. It's great.
All right. Thank you.
Thank you so much.
Yes,
Thank you
thank
all.
you very much, everyone.
Thank you,
Thank
Nat.
you.